the Focal Therapy Society Registry update, and Focal Therapy Society publications for the past year.
Thank you for your attention. It's a pleasure to be here. This is our 15th meeting. It started in 2008 with just an idea and some passionate people, and I'm very pleased to see that it's continued. So I'd like to talk about what we've been doing with the registry that we built, and I have no relevant disclosures. So we've been working together since 2008, and I'd say since about 2010 we've been working. Each meeting we would try and come up with two topics, maybe one kidney, one prostate topic. We'd have consensus panels, usually following the Delphi process, and we would publish one or two white papers every year. And you've probably seen a number of them already. They've looked at such topics as patient selection, which is the better way to target, how to judge outcomes, etc. And we've continued to do that, but we have new challenges. So we now have a registry. We've been building this as we go, and the question comes up, why is a registry necessary? So if you look at the guidance, the AUA feels that ablation can be considered in select informed patients within a clinical trial or prospective registry. The EAU says essentially the same thing. It should be done within a clinical trial or prospective registry. NICE also feels that registry or randomized trials are the best way. So I think all the regulatory bodies feel that registries or trials are best. We can't all have trials, but we can have a registry. And so for me and Dr. Robertson, who are both at Duke, all of our patients that are undergoing focal are on registry. And I would encourage you to also put your patients on registry. This way we're following the guidelines and also hopefully delivering exceptional care to our patients with low morbidity. The objectives of the registry to allow high quality data capture, determine oncological and GU functional outcomes in prostate cancer patients. We do understand the great need to collect the data because patients are opting for this and they want to know the outcomes. They want to know about the reduction in morbidity on GU function. And you know, we also understand that although we'd like everything to be a level 1 trial, we often practice without level 1 data. And as mentioned in the prior session, we have a trial that has level 1 data with TUCAD, and yet we don't really use that. So not everything in an RCT translates to clinical practice. So data is abstracted from the electronic medical records, looking at diagnosis, treatment, surgery, follow-up every 6 months for 2 years, and then we're going to do it annually through 10 years, longer if you're willing to participate. Collaborating sites may provide as much or as little data as they can, including longer follow-ups, and patients will be followed as part of the registry until death if we're able to go that long. The data that we're collecting is the demographics, baseline and follow-up clinical data, GU functional outcomes. We have imaging built in, prostate biopsy, details of the ablative procedure, ablation patterns, any device or ablation pattern can be used, any type of adjuvant or secondary treatments. The only thing we're not collecting is biospecimens. This is a list of the current status of the Focal Therapy Registry. These are the sites that are onboarded or putting data in currently. You can see that we're extending into other parts of the world. We have a site now in Brazil. We have one in Buenos Aires, Singapore. We have other Asian sites coming up, and we have some sites that are coming up in Italy and Spain, a couple in Canada, They're still onboarding. So this is truly an international effort, and I would highly encourage everyone to put their data in the registry. Now, you can publish your own data. There's no problem. I publish all my studies, but at the same time, I put our data into the registry so we can pull them and look at more meaningful, larger outcomes that will help push the field forward. So this is the available data that we currently have. We have a little over 1,500 patients, most of whom have had primary therapy, but we're also collecting data on salvage. And then you can see some of the various instruments that we're using: cryo, HIFU, laser, TULSA, IRE, photodynamic therapy, RFA. So basically, we're device naive. And again, we encourage you to participate. So in terms of publications, this is one here. It's the first abstract of the Focal Therapy Society Registry. It was presented at AUA 2024. Focal cryotherapy for localized prostate cancer, an initial report from the International Focal Therapy Society Registry. So we're trying to embark on clinical trials. So the Focal Therapy Society, in conjunction with Endo Society, perhaps will be launching a clinical trial platform. Perhaps in the future that we can work together to run clinical trials. This is just one such idea: optimizing diagnostic prostate biopsy template. The DETECT trial, you heard about today, different ways to biopsy. Perhaps we're moving away from standard 12 core plus targets. There's new ways to do this. I want to give a shout out to Andre Abreu and his colleagues at USC. This is one of the projects that have recently been done, the Delphi Consensus. It's a consensus for best clinical practices on transperineal prostate biopsy. So the Focal Society, we do everything from biopsy to imaging to targeting to treatment. That's all in our wheelhouse. So this is our first best practice statement. We're coming up with more. Primary whole gland ablation for the treatment of clinically localized prostate cancer, a Focal Therapy Society best practice statement. So the question may be raised: why is the Focal Therapy Society riding on whole gland? So two reasons. First reason is that we've had a wealth of experience with HIFU and cryo internationally over the years, and no one's really codified it. So we took it upon ourselves to summarize that with a systematic review, meta-analysis on whole gland therapy, and that was published last fall in European Urology. The second motivation for that is you all heard about how cryo has FDA approval, has a CPT code, it's considered standard of care, yet at Duke, Blue Cross Blue Shield, North Carolina said that cryo is experimental. So, I mean, that just blew me away. I had no idea it was experimental. Of course, they don't want to pay for anything they don't have to. So they said the reason was because cryo, even though it's FDA approved and has a CPT, didn't do a head-to-head with surgery. I told them, well, that day's passed. We're not going to run a head-to-head trial. So we did this, and we brought them the information. They said, so it looks like you have data. So case closed. So this is why we need to work on things together. Upcoming publications, we have a very nice paper right now that I'm sure many of you have participated in. Salvage ablation for radiation-recurrent localized prostate cancer, again, is another best practice statement, and right now it's under submission. There's more than 100 co-authors, international experts around the world. We have an active surveillance consensus statement that we're wrapping up and we'll be submitting soon. And then we have our first textbook. This is the Focal Therapy Textbook on Imaging and Focal Therapy of Early Prostate Cancer. 41 chapters covering different areas of focal therapy, over 130 co-authors, and it's coming out this fall, 2024. I know a number of you have participated in this, but these are all projects that we're doing through the Focal Therapy Society to make it better for not only us, but our patients. So you're all invited. The best is yet to come. If you want to join and support the registry, You can scan this or you can write me and we'll put you in touch. I think we have a lot of exciting projects and we tend to work better when we work together. So again, if you want to support, there's not many things you need to do. You have to first become a member, and you can join either the Focal Therapy Society or the Endourological Society. It's one membership for both societies. And you need some local IRB approval, and then we have a data user agreement that you would sign, and then you're in. You can put your data in, you can take it out, do whatever you want. I would mention that we had a very generous donation from AngioDynamics to sponsor this, and I would hope that we have other corporate support going forward, but we now have worked with a third party that can help you enter and maintain the data at your site. So if you feel that managing data is too difficult, because I know physicians are busy, there is a third party data management company that will manage the data for you. So thank you very much for your attention, and I hope you all participate.